Hello friends, and welcome to Sterile Field Guide, a podcast dedicated to medical student general surgical education. I'm Alex, and I'll be your guide. Hello friends, welcome to episode 3. In this episode, we're going to talk about how to see a consult. In the last 2 episodes, we talked about how to present a patient as well as how to pre-round. So this episode is sort of going to be a culmination of those 2 things. If you're not familiar with what a consult is, this is when you are on a specialized team and someone else in the hospital asks you to come see their patient for whatever reason. So a common example of this is a patient comes into the emergency department with abdominal pain and the emergency medicine physician thinks that it could be surgical, and so they're going to consult the general surgery team. So some of the elements of a consult are things that you're already familiar with, like taking a history of a patient. And to do that, you're going to want to be able to pre-round on these patients as well as present them when you're finished. So let's talk about what happens in the in-between. So before you ever see a consult, you should absolutely chart review them. You should read about what has been done for them already and why they are in the hospital to get a sense of who the patient is and what they're presenting with. Sometimes you'll be consulted late in somebody's hospitalization, so a lot of things will have been done for them, and sometimes you'll be the first team consulted immediately when they enter the emergency room. So it's sort of different based on different patients, but this is a good time for you to check out their chart, look to see if they have any labs or imaging back that will help shape your differential. Speaking of a differential, you should think about your differential given their symptoms or their history, and it could be a good idea to write these things down and think about what might rule these things in or out in your history, because the point of a consult is for you to go in to figure out sort of what's happening or what needs to be done. And so if you have a large differential and you know that, okay, let's say appendicitis is on my differential, I know if I press on McBurney's point and I do the psoas sign and both of those things are negative and the pain isn't in this area, I'm less concerned for appendicitis. And so writing those things down and what of your history or your physical could rule those things out can be helpful when you finally do see the patient. If there is a physical exam maneuver that you think would help you figure out what is most likely on your differential, you might consider writing this down as well. For example, when I was on medicine, this isn't surgical, but when I was on medicine and had a lot of CHF patients, I would always have to remind myself to look at the JVD. So if there's something outside of your normal exam that you're likely to forget to do, I would write this down, especially if it's going to help narrow your differential. So now we'll move on to seeing the patient. Some things to think about when you're seeing the patient. There's a mnemonic called AMPLE. AMPLE is an approach to gathering a history, and it stands for A, allergies, M, medications, P, past medical history, L is last meal, and E is events or environment. So allergies, this is pretty self-explanatory, but you're going to want to ask the patient what their allergies are as well as what their reaction is, because some allergies are listed in the chart as allergies that are simply reactions, and knowing if something is a true allergy versus a sensitivity is important if you really do need to give that patient a medication. The medication list, this is always important. I know that it's maybe my least favorite part of gathering a history, but taking a medication history is really important. Noting what they take, the dose, the route of the medication, so if it's oral, injection, rectal, etc., and why they take that can be really important. And it's important to ask these questions because your team is going to want to know, especially if this patient hasn't been admitted to the hospital yet, what medications this patient needs to be started on right now and what medications they can wait to have started later. But knowing what they're on at home is an important thing to start with. You should also prompt patients to tell you about inhalers, supplements, birth control, etc., because sometimes people forget that these are medications. While all medications are important, it is especially important in surgery to ask about blood thinners. You should absolutely know if your patient is taking blood thinners, and patients, again, will forget that what they're taking can thin their blood. That's not something that everybody knows. So providing a list to patients, you can say, are you taking blood thinners? And if they say, yes, I'm taking something that starts with a W, you're like, okay, maybe warfarin. But if the patient says, I'm not really sure, you can say, okay, do you take aspirin, goodies powder, ibuprofen, heparin, warfarin, Eliquis, etc.? Like, you can provide them a list, and if they're like, oh yeah, I actually take aspirin every single day, or this dose of goodies powder every time I have a headache, which is every single day, like, that's important to know. For past medical history, this is sort of run of the mill. You know how to take a past medical history. Just ask the patients, like, do you have any medical problems? Diabetes, hypertension, the common things, and then anything else they've had. It's also important in surgery to ask in the past medical history about past surgical history, especially if somebody, for example, is presenting with something that you think might be an obstruction. If they have had abdominal surgery in the past, this is going to increase the likelihood of this on your differential. So it's important to know if people have had surgeries. If you're concerned about like cholecystitis, but they don't have a gallbladder, that's going to be important for you to know. For last meal, this is important to know the last time the patient ate, especially if you're considering surgery. And ideally, patients should be NPO about 8 hours before surgery, but this can be different based on your institution. But in summary, this helps inform how anesthesia is going to interact with this patient if emergency surgery is indicated. And you asking this question, especially if emergency were to arise between when you see them and when you get up to present the patient, this can help reduce aspiration, which can have pretty high morbidity for patients. And then for an events and environment, this is essentially like what happened today that brought this patient into the hospital. Sometimes it will be fairly obvious, like if you're with a trauma patient, the events that brought them in are the trauma. But if this is a patient with like a chronic condition and now they're coming into the hospital, it's sometimes important to ask what changed that prompted you to come into the hospital, because sometimes people will note a change in their symptoms that they're not telling you before you ask this question. So more things about the history. It is a pro tip for gathering a history. It is nice to gather this history at the patient's eye level instead of sort of towering over them and looking at them. It's not always possible, but if you're able to sit down with the patient, this has just been proven to make patients a little bit more comfortable and make it a little easier for them to open up. Things to think about when you're doing like a history of present illness. There's another mnemonic you may have heard of that is OPQRST, and this is more like a symptomatic history gathering, but the O stands for onset, P for pain, Q for quality, R for radiation, S for severity, and T for timing. Onset, when did this symptom start? Pain, where is your pain? What is it like? Quality, what is it like? Radiation, does it move from one place to another? Severity, on a scale from 1 to 10, with 1 being the least and 10 being the worst pain of your life. And then timing, is it worse at night? Is it worse after meals, etc.? Another question you can ask is, does anything make it better or worse? Have you had these symptoms before? And do you have any other associated symptoms? Which you can also gather in your review of systems. Sometimes patients don't know what associated symptoms means. So you can just say, do you have any other symptoms right now besides your belly pain? And then you can do your review of systems and say, like nausea or vomiting, changes in your vision, trouble swallowing, etc. So moving on from that portion of the history, taking a social history is really important when seeing a consult, and your team will appreciate if you gather this information. Some things in a social history that are actually extremely important. I know a lot of people like to skip this because they don't think that it's important. Alcohol use is extremely important in a social history, especially if patients are going to be admitted inpatient. And the reason why, you'll see this on step 1 and you'll see this on step 2, is that if a patient goes into delirium tremens, this is an extremely preventable disease, and you have to know if the patient drinks alcohol and how much they drink to prevent it. So asking questions about alcohol, you want to remain neutral when asking these questions. So you can say, do you use alcohol? Okay, yes. How many drinks per day? How many drinks per week? How many drinks per month? If they say, oh, I don't drink every day, you can sort of widen it. I would try to normalize this as much as possible. We're not trying to shame patients when gathering this information, because if people shut down before we can get it, it gets harder to prevent adverse outcomes. And then when people provide you a number, so if somebody says, oh, I have 3 drinks per day, it's important to ask what those drinks are. So if somebody's having 3 beers versus 3 mixed drinks that they're mixing themselves, these are not the same. They could be the the same, but you need to ask like how many shots are in each of your mixed drinks, because if there are 2 per drink, that's the equivalent in alcoholic beverages as 6 beers. And so you need to know that when you're asking these questions. For substances, similar motives for asking. It's helping to prevent withdrawal, making pain plans in the hospital if people are using opioids or other pain medications outside of the hospital. It's important to know this when trying to manage pain, as well as if a patient has a pathology that could be caused by the use of certain substances, like cocaine, for instance, can cause a lot of vascular complications and can lead to people presenting to the hospital with a real medical condition, and knowing like, okay, you're a 30-year-old with this weird chest pain, what's going on? Okay. Like if you have a past medical history of using things like cocaine, that can help us narrow the differential and the diagnosis quicker and get the care that these patients need. For tobacco, asking if your patient smokes, this is important, especially for me. I feel like it's important to address this because if a patient needs support in quitting smoking, that's something that you can provide inpatient. But also, if a patient has no interest in that right now, but they're having an acute complaint, it would be absolutely horrible, I can only assume, to be withdrawing from nicotine while you're also extremely sick in the hospital. And nicotine patches and lozenges are absolutely something you can offer in the hospital to make sure your patients aren't miserable on top of being extremely sick. So I always like to ask about tobacco use, and that's the reason. I don't want my patients to be miserable on top of being sick, but also if they do want support in quitting, that's something we can provide. Another thing people sometimes forget to ask about are like activities of daily living. Some things I think are particularly important is if the patient uses hearing aids, has glasses or dentures at home, so any of these assistive devices. If the patient is going to be admitted inpatient and they're going to be here for a long time, knowing that the patient can't see or can't hear or can't eat their food properly without these devices can help us prevent delirium, which has real life consequences the outcomes are not awesome. So we want to prevent delirium in these patients, and recognizing early that they do have these devices at home can help us with that. And then finally, something that I think if you are able to and your team allows you to is asking about code status, or at least prompting this conversation. You may check in with your team to see if like a medical student having this conversation counts as an actual documentable experience, because if it doesn't, you may not want to have this full conversation with the patient before the resident physician can. However, if you can, I would encourage you to ask to watch these until you feel comfortable doing them yourselves, if your team will let you. Some things to note is that institutions will have different rules about what is like an available code status. For instance, the institution that I'm at, you cannot be full code but refuse to be intubated. So if the patient has like, call it limited resuscitation, it's not actually, unfortunately, a valid code status at my institution to be full code, but I don't want to be intubated because that doesn't follow our protocols and we won't do that. So don't offer that to a patient if that's not something that your institution will actually do. So note what you can do, and asking patients about their preferences, I think, should apply to every patient, regardless of their age, regardless of the severity of their illness, because patients are extremely unpredictable and can do things that you don't expect, and it's better to ask the question than to guess later on. For your physical exam, some things that people sometimes miss are like noting the vitals when you're in the room. So many patients are on the monitor, whether or not they should be. So always take a peek at the monitor, look at the tracing, the heart rate tracing on the monitor as well. Sometimes there are important findings on the tracing. For instance, one time I was on a neuro rotation and the patient was dizzy and we were like, what's going on? I took a look at the monitor and their heart rate was 35. And so that made a little bit more sense that maybe this is not a neurologic problem. Maybe your heart rate is 35 and it should not be that low. So always look at your vitals, write these down when you're in the room. This is important. If you see something on the monitor that is suspicious for a STEMI, like a heart attack, you should call your team and notify anyone with with any sort of power within earshot that you see something wacky on the machine. Sometimes like something that looks like a STEMI on the monitor is not actually a STEMI, but it's important to say something instead of think, okay, well, I don't actually know that this is anything, because it would be bad if you missed it. Again, we talked about thinking about what physical exam maneuvers you wanted to do before you go into a room, so this would be the time to do it. For a physical exam, I would recommend that you do like a limited full physical every single time, so heart, lungs, abdomen should probably happen every single time you see a patient, and then add on to that if they have specific complaints. So the final step of seeing a consult is presenting your patient to your team. I would recommend taking a little bit of time to get organized before you go to present the patient, because typically, unlike morning rounds where you've been following this patient and kind of have a sense of what's going on at baseline, this is a brand new patient to you. You are the person who knows their history, nobody else does, and so it's important for you to succinctly summarize and say the things that are necessary for the team to know while also not leaving out important information. So take a little time to get organized, narrow down your differential, note what physical exam maneuvers you did that rule in or rule out specific things, and then at this time you can make your problem list and then prioritize it, or make your differential. So if when you went into the room all you knew was this patient had abdominal pain, your differential could include a number of things, but let's say that it's appendicitis, cholecystitis, small bowel obstruction, and acute mesenteric ischemia. And if you know that they've had their appendix and their gallbladder out, and the timing of their abdominal pain is not consistent with acute mesenteric ischemia, you can say, my differential includes a small bowel obstruction in the setting of prior abdominal surgeries. This is the highest on my differential for these reasons. Like acute mesenteric ischemia is lower on my differential for these reasons, but could still be possible. And then I have ruled out cholecystitis and appendicitis because the patient no longer has these organs. You can do your differential like that. But it's important to sort of prioritize this as you're going in. You can also make a problem list. So if you are going to do a plan by problem or a plan by system, this would be a good time to decide which one you're going to do. Making a problem list, prioritizing the problem list. I think prioritizing a problem list is extremely important when presenting, because it holds people's attention and shows that you know how to decide what deserves more attention than other things. And so if the things on the problem list are this patient has a stub toe, this patient has frank peritonitis, and this patient has like a mild anemia, and you're saying stub toe, anemia, small bowel obstruction causing peritonitis, you should absolutely flip that, because the things that need intervention you should say first. And then, as always, I would encourage you to suggest a plan for each problem, even if you're not sure, because this is the whole point of medical school and having clinical experience, is being able to practice. And the more you push yourself to be independent and think about the plan for something, the better you will become at being independent and thinking about the plan for something. And this should be a relatively low stakes environment, although sometimes teams aren't very nice. That is possible, that can happen, but this is for your learning, and I believe fully that doing these things and participating in suggesting a plan for each problem is really good for you. And that is how to see a consult. I know that is like a super broad overview, but I hope that this is helpful when approaching your very first consult or just brushing up on your skills after a little bit of time off. I hope you enjoyed this episode, and I'll see you next time. Bye. That's it for today's podcast. You can support this podcast and receive exclusive educational content on Patreon, and find us on Instagram at Sterile Field Guide. Questions and requests can be submitted to our Gmail at sterilefieldguide@gmail.com. Thank you for listening, and until next time, may your retraction be superb and your suture tails be the perfect length.